So good morning. Welcome to the final grand rounds of the year. We have a great agenda on this morning. I'm going to first introduce Rudy Rodriguez, who's the new service chief at the VA, who will in turn introduce Jake Berman, who's chief res at the VA and is going to be giving grand rounds this morning. And then stay on, please, at the end when Ken Steinberg will be up here giving an award from the residents for research mentorship to one of our faculty. So a great morning, and again, the final grand rounds of the year. We usually start up again toward the end of August, so those announcements will be going out as we get to that time. So let me go ahead and introduce Rudy. Rudy has been on our faculty for 6 or 7 years. He's, but in the last few months, has become the head of hospital and specialty medicine at the VA and vice chair of the department. And he's a native Californian, got his undergraduate degree at Stanford in human biology, MD at UCLA, residency and fellowship training in San Francisco, and then junior faculty through associate professor at UCSF in nephrology, where he was chief of nephrology at San Francisco General. He became the fellowship program director in nephrology at UCSF, which position he held for 8 or 9 years, and also received several remarkable awards from the faculty at UCSF, including Distinguished Consultant Award from the other faculty, and was in the inaugural group of 6 UCSF faculty picked to be distinguished clinicians. We were fortunate to recruit Rudy here, as I say, 6 or 7 years ago, as head of the nephrology section at the VA and also head of the dialysis program there. He has progressed through our ranks to become a full professor 3 years ago. He has also become the director of both the dialysis unit there and then the nephrology fellowship program for the division as a whole. About 5 or 6 months ago, we're fortunate to recruit him into the position as head of hospital and specialty medicine at the VA, which essentially is the same as what used to be called the medicine service, except that primary care has been separated out into a distinct service, also directed by one of our faculty, Connie Morantis. Rudy has done a terrific job throughout his career here. He's expanded his influence to the national scene as the American Society of Nephrology, on the executive committee of the training programs nationally. His research areas are in viral infection in causing kidney disease and the effects of geography, race, and poverty on the development of chronic renal disease. So please give a warm welcome to Rudy, who will come up and introduce our grand round speaker.
Thank you, Bill. And thank you also to Bill and the rest of the committee, which included Steve Fenn, Connie Morantis, I think, Ginny Brody and Brad and others for this opportunity. So again, thank you very much. Some of you may be wondering why it took him 6 months to introduce me. I asked him the other day, but I think because things have settled down in the VA, there aren't any controversies now. He's sure I'm not leaving, so he thought it was time. But enough about me. So I'm here to introduce our speaker, who's Jake Berman, who's going to be talking today about Part Hedgehog, Part FOX, the Affordable Care Act comes of age. One of the best parts of actually this job has been working with the chief residents, the inpatient and outpatient chiefs. So that's been great. So Jake actually was born in Chicago and grew up in Massachusetts. Did his undergrad at Brown in history, and that probably explains why he starts most morning report actually with a little history lesson, which has been very enjoyable. He then actually had a break between college and med school, and was in a group called The Road Less Traveled, which I think introduces high school kids to travel to western parts of the U.S. He traveled to Costa Rica, to India, and that's an experience he shared with his future wife, Anita, who's here. And they were married about 4 years ago. He entered Tufts University and got his MD and PhD there. He was the co-president for Physicians for Human Rights, and the editor and a columnist for the Tufts Connective Issue, which is their newspaper. Like that name. I can see as a future like Paul Krugman type. He then entered our program, and in recognition of his excellence, became a chief resident. He's done an incredible job, actually, as chief resident. He spearheaded the development of our health systems curriculum and the launch of the cost consciousness care training for our residents. And even in the last couple of days, actually, I've gotten some emails unsolicited about some of the value that he's brought. Like Steve McGee sent me an email yesterday, or copied me on an email to Jake, which says, "Hi, Jake. Just finished sitting down with all the students, talking with them one-on-one. When asked about what was good and not so good at the VA, resident report and your teaching was ranked as the #1 educational activity on their list." I also got another unsolicited email yesterday from one of our administrators, just really praising the value about all he's done for the hospital and the kind of administrative projects that he's accomplished. So he's been a great addition. We started about the same time as kind of his inpatient stint, and I knew both of us would do well because I think both of us, when we're faced with kind of these absurd situations that happen in the VA, we kind of just accept it and say that's the way it is. Like early on, he kind of came to me and said, I want to run something by you, and it had to do with the fact that he was getting these angry emails that the chief resident room was actually the lactation room for nursing mothers. It seems absurd that the VA would need that, but when you think about it, of course we need it, and because of workers and all that. And he actually adapted well, and it became the chief resident / lactation room. And it's not been a problem the whole year. The union actually has been quiet about it, no problems. Most recently, actually, the most recent thing we dealt with is both of us have been working very hard on the chief of medicine rounds, kind of making it a very interactive, interdisciplinary conference. Actually, I haven't been working very hard. He's been working very hard doing this, and it's been a success. We needed actually a much bigger room, actually. We actually moved to the chapel, and that's where we actually have the chief of medicine rounds. And that's not the absurd part. The absurd part, actually, is that about a month ago, we lost the room because of a Zumba class. The Zumba, I don't know if you know what Zumba is, but apparently it's an aerobics / Latin dance, like samba, merengue, you do to aerobics. And that actually then was going to happen instead of chief of medicine. So we actually talked about different strategies to get the room back, like talking to the chaplain that it's probably not that dignified to have the Zumba class there. At one point, we actually thought about having kind of a face-off, both of us going there at the same time. The Zumba class with kind of the spandex VA workers there ready for the class, and then kind of the VA crowd, people like Jan Hirschman and the medical students. We could take the room back, but in the end, we decided that might not be a good idea. And he finally, I don't know how he did it, he got the room back, and we're back there. So that's enough of that. But so let me introduce Jake. Looking forward to your talk. And I'm really sorry that he's actually going to Harborview next year, but just know that that you're always welcome to come back. So Jake Berman, please.
Thank you, Rudy, for that generous introduction. Good morning, everyone. It's really wonderful to see you all. It's a privilege to be here. Last night, I have to admit, was a bit of a stressful night. As many of you know, I developed a reputation for being somewhat attached to a certain black fleece vest. And so I was up late trying to figure out, is this something I should wear today, or does Grand Rounds merit an exception? So I decided to take it to the next level, and I've got my black jacket here, but lest you be concerned, the fleece vest is right here, and should things go south, it'll be kind of my teddy bear. So, all right, so into the talk. As Rudy said, part Hedgehog, part Fox, the Affordable Care Act comes of age. I always feel like you can maybe get a couple bonus points out of the gate if you pull an intriguing quotation, especially one by an ancient Greek. Fox knows many things, but the hedgehog knows one big thing. This is from Archilochus. And some of you are familiar with this, and for those who aren't, the correct response is, Yeah. We'll come back to this later in the talk. Disclaimers for me. I have no financial disclosures that I'm aware of. I do have some other just notes up front I want to mention here. So when I sat down to think about how to present this talk, I thought I have two choices. I can either do a deep dive into some particularly pertinent element of this vast constellation of rules and initiatives called the Affordable Care Act, or I can do kind of a big picture, how do the moving pieces fit together? And I tend to be a big picture kind of guy, so I opted for the aerial view of the Affordable Care Act. Second, I just want to dispel right up front two common misconceptions about insurance. This will not be an exclusively insurance-focused talk, but insurance is a major theme. So there are these two misconceptions that insurance is, one, boring, and two, hopelessly complex. And if you look closely at the literature, it actually turns out that insurance is, in fact, fascinating and exciting and not boring. And it is complex, but it's not hopelessly complex. We have a complicated health insurance system, but I think we can figure out ways to understand it. And then finally, if you've been paying attention at all, you might notice that health policy occasionally becomes slightly politicized. And I've done my best since I kind of became seriously interested in this topic a couple years ago to approach it the way I think a Martian would. And what that means is Martians are generally free from earthly political biases. And so this is obviously aspirational, but I do my best to take an even-handed approach on this topic. So, into the morass here, public opinion on the ACA. If you look at public opinion tracking polls since the ACA became law, which was back in March of 2010, you'll see pretty consistently about 35 to 45% of people favor the law, about 30 to 40% oppose it. But it all depends on how you frame the question, consistent with Dr. Mills's great grand rounds of last week. And so some of you may be familiar with the work here of the great health policy wonk Jimmy Kimmel, who on his late night program back in the fall interviewed a series of people on the street in Los Angeles and asked them a question: what do you prefer, the Affordable Care Act or Obamacare? Now, I hope it doesn't come as a shock to anyone in this room that those are in fact the same thing. But lo and behold, everyone who he interviewed vastly preferred the Affordable Care Act to Obamacare. So it's critical that you frame this in the right way. What about us? Are we so much different? Are we so much better in the healthcare industry? Well, Quanti MD, which is a physicians organization, back in January conducted this poll, and it showed that about 84% of physicians don't think they have enough information about the ACA to serve as a reliable resource for their patients. And 81% don't think they have enough to understand its impact on their practice and to comply with its requirements. And a couple years back, some of the residents will remember this, I was interested in what UW residents knew or thought about the Affordable Care Act. And I sent out a survey and asked a number of questions, but this was kind of the key result in my mind. Most people, 70+% said, yeah, they know the key features, but most of the details, frankly, are a hazy maze. There were some people down at the bottom there who were brutally honest about their experience with this law. I suspect that number might actually be a little higher. So the agenda for today is really to tackle three broad questions. The first is, for context, reminding all of us why something needed to change. Why did something need to change? We'll touch on that briefly. Second, what change has the ACA brought? What change is it bringing so far? And then finally, I'll talk a little about what this might mean for all of us as providers, patients, and citizens, because most of us in this room are actually affected by this law and by the changes in healthcare reform more so than your average citizen. So, why did something need to change? And just to frame this up a little more, I always find it helpful to think about healthcare systems in terms of these four principles: quality, access, equity, and cost. And the goal of any healthcare system, I think, at any level of jurisdiction, is to try to optimize around these parameters. So for the final decades of the 20th century and into this century, we were kind of in a state of escalating crisis affecting virtually every stakeholder in the system. And we hear about this, big picture, and I'll come back to some of the data, but I think to make it a little more vivid, I want to introduce you to four archetypal characters who some of the residents will be familiar with these folks, but they're having new adventures today, I assure you. So the first is Anita, who's a 42-year-old programmer over at Microsoft. She's insured through her employer, and I was actually for the first time able to score photos of these folks today. So that's Anita. Next up we have Jack, who's a 71-year-old retired lumberjack on Medicare, and he's kind of a crotchety old fellow. We know the type. We all care for patients like him. And there's Chad, who's a 33-year-old microbrew entrepreneur, true Seattleite, and he's insured on and off through individual market plans. He may be in the room right now, and he's a man of his trade. And then we have Michelle, who's a 29-year-old single mother of two who's uninsured. And behind that warm smile, she actually has a lot of stress, a lot weighing on her mind. So let's just walk through briefly the experiences of these four individuals in the pre-Affordable Care Act world. So again, this is Anita over at Microsoft, and she's among the 60% of non-elderly Americans in the employer-sponsored insurance market. And this is familiar to virtually everyone in this room because pretty much all of us get our insurance through our employer. And her experience in a nutshell: good coverage, the costs are rising, but they're generally manageable for her. She has stable insurance unless she becomes unemployed, in which case she's got this thing called COBRA that will extend it for a certain temporary amount of time. And her employer shares in premiums and other costs, and this is incentivized by federal tax policy. Yeah. That's a great question. I'm so glad you asked that. So the question was, what are the three largest government expenditures in healthcare? Maybe it would help people to see it. So, does anyone know what are the three largest government expenditures in healthcare? What's number one? Medicare is number one. What's number two? Medicaid is number two. And what's number three? What's that? The VA? No, not the VA. That would be very helpful if that were the case, but no. Number three is what? Yes, the employer health insurance tax exclusion. And this, again, is familiar to a lot of people in the room, but essentially, since the days of World War II, whatever your employer kicks in to cover your health insurance premiums, and in most cases, whatever you as an employee kick in, all that is excluded from taxable income, excluded from income tax and payroll taxes. As a result, the government foregoes about $260 billion in revenue annually. So let's move on to Jack and Medicare here. So again, we care for a lot of Medicare patients in our system, so this is not shocking news. His experience is generally stable coverage. He lives perilously close to this prescription drug donut hole, right? Meaning that his prescriptions are covered up to a point, and then he falls into this donut hole and has to pay out of pocket, and then once it reaches a catastrophic threshold, then his coverage kicks in again. He's got poorly controlled diabetes, but he doesn't really notice the symptoms. Doesn't think there's anything wrong with him. Familiar at all, maybe? And mostly he's worried about his kids and his grandkids. Is there going to be a Medicare around for them? Chad and his beer. So Chad's among the 12 to 14 million Americans who gets his insurance through the individual insurance market. And this, frankly, was a nightmarish experience for many people. The plans are costly. It's difficult to even figure out what it's going to cost you initially because it's hard to shop transparently for these plans. The coverage is limited. Your coverage can be refused or cut off. And there's a high barrier to getting high-value services. And last but not least, there is Michelle, who's uninsured and particularly at Harborview, but throughout our system we care for patients in her predicament. Among the 50 million Americans back in 2010 who are without health insurance, care is very sporadic, minimal access, low quality, not in the sense of low-caliber providers, but just limited continuity of care. And the biggest stress is that financial ruin is always looming. So, in sum, these experiences have led to numbers like this. And if you look at us compared to our high-income peer countries, OECD being the Organization for Economic Cooperation and Development, high-income countries. Back in 1990, we were 14th in healthy life expectancy. 2010, we dropped to 26th. Even though the absolute number improved, we're falling behind sort of our peer countries in these key metrics of quality. 27th in infant mortality in 2011. But all of this was not for lack of spending. And I think a lot of you have seen graphs like this before. GDP per capita on the x-axis, and we have healthcare spending on the y-axis. And basically, you'd expect that as countries become wealthier, they'd spend a higher proportion of that wealth on healthcare. But we are way, way off that best fit line there, spending now well over $8,000 per capita on healthcare each year, which is unsustainable, and partly because of all of this data. Back in the year 2000, the World Health Organization, in its first World Health Report, ranked the United States healthcare system as 37th in the world. And this was so unpopular as to compel them not to issue rankings when they did their next World Health study in 2010. But the data is there for all of us to see. So just a quick status check. How are we looking on the eve of the Affordable Care Act? And I think you can see we had tremendous problems throughout all these parameters here in terms of cost, in terms of a huge number of uninsured and imbalances in our system. So, what change has the ACA brought? Well, the big picture, this is a sort of excruciating giant document of legalese to try to sift through. 2,700 pages, 20,000 regulations. So I've tried to boil it down into three fundamental bullet points right here. First, major reforms to private insurance, and we'll talk about that in some more detail. Second, expansion of public insurance coverage. And then third, and this is a complex category, new resources to help drive innovation and quality improvement and cost control and in delivery system transformation. That's kind of the buzz term. So let's head back to our characters here. This is Anita at Microsoft. She's getting insurance through her employer. And essentially under the ACA, she's in one of the cohorts that is potentially least dramatically affected. She continues with her employer-sponsored plan, but she does know that she has some new protections. Under the Affordable Care Act, there are no lifetime or annual caps on your coverage. And you know that if you do shift plans, you can't be denied for pre-existing conditions. She knows she'd have an easier time finding insurance if she were fired because of these health insurance exchanges that I'll talk about more in a few minutes, but I think most people are pretty familiar with them by now. Some colleagues do say that their plans have been downgraded. Now, why would that happen? So I mentioned, and we talked about the employer health insurance tax exclusion, that $260 billion of revenue foregone annually. One feature of the Affordable Care Act is to implement what's called the Cadillac tax, which is essentially a partial capping of that tax exclusion, meaning that come 2018, certain expensive insurance plans offered by their employers will be subject to income and payroll tax above a certain threshold. And that may drive some of the most generous plans to become less generous over time. Finally, she enjoys no cost sharing at the point of care because under the Affordable Care Act, any preventive service that receives a level A or B United States Preventive Services Task Force recommendation has to be provided, covered by the plan without any out-of-pocket cost for the individual. So there's been a lot of speculation on what this is going to do to folks like us who are in the employer-sponsored insurance market. There are some studies predicting that, by 2020 or so, there's going to be a very minimal employer-sponsored insurance market, partly because of the Cadillac tax, partly because people like us will have new viable options for insurance elsewhere in the healthcare system. At the same time, there is, or allegedly there will be, an employer mandate to compel larger employers to provide insurance for people. And there's also a very established track record of employers offering health insurance. So a lot of people are skeptical that this is going to come to pass. And we've seen recently here different developments in sort of employer-sponsored insurance with the big Boeing Accountable Care Network contract with UW-Medicine. And this is, I think, sort of very much a harbinger of things to come, where employers and healthcare systems are entering into these relationships to care for a population in a way that incentivizes cost control and quality. So, lumberjack. So Jack on Medicare, again, is in another cohort that will be affected in some ways, but much less dramatically so than many other people in the system. His care stays essentially the same for now. He does have these fully covered annual preventive health visits. He notices his clinician seems vaguely annoyed every time they comes in for one of these visits because of all the box checking and these forms. The deductible's waived for his colonoscopy because that's free at the point of care. The donut hole will be filled over time for him. And his PCP joins an accountable care organization. What does this look like to Jack? Well, maybe his doctors are a little more clued into what's going on with him. Probably the biggest effect for him is that people are pestering him more about his A1C of 13 and his blood pressure of 190 over 100. There's a ton of other stuff in the Medicare realm under the Affordable Care Act, and that would be a separate talk into itself. But I wanted to highlight one, I think, particularly exciting and potentially high-impact feature, which is that the ACA allocated $10 billion over 10 years to establish an innovation center at the Center for Medicare and Medicaid Services. And this is essentially a center that looks to issue grants to healthcare systems and to states to support pilots and initiatives that have the double aim of improving quality and improving cost control. And I actually had the opportunity to sit as a grant reviewer on one of these panels back in the fall, and we were looking at all these proposals from healthcare systems across the country, particularly from the realm of oncology and palliative care. And the common themes were things like moving toward better longitudinal care at the end of life, shifting care from high-resource inpatient settings to outpatient settings, even to the home, integrating electronic medical technology better into care systems. And the government is very serious about making sure there's a return on investment in this. So the instructions we were given as a review panel is that for any grant that was going to be awarded for 3 years, the expectation is that there'd be a 3-to-1 return on investment in that span. And the idea is that this is not just going to drive reform in the public sector of healthcare, but it'll be sort of a leader and help drive reform in the private sector as well. And there are a lot of efforts to enlist private payers in these efforts. So that's one thing to keep your eyes out for. Washington State has been on the forefront of this and is one of the states that's applying for a large sum of money through the Innovation Center to run a state healthcare innovation plan. And again, I'm sure some of you are familiar with this, but essentially the state has a very ambitious agenda for what it would like to do with several million or tens of $1 million from the Innovation Center. And I think this is context for all of us for the next few years. There's kind of a big three-pronged approach, which is drive value-based purchasing, with the state leading the way. And you can rub your eyes and wonder if this is realistic, but they seem pretty serious about this plan of shifting payment 80% in the public sector to outcomes-based metrics, away from fee-for-service, and 50% in the private sector within the next 5 years. The other pillars here are establishing healthy communities, so sort of accountable community organizations, and this is particularly important east of the Cascades and the rural parts of the state, trying to set up community-based systems that provide better preventive and chronic disease care, and then improving the integration of physical and behavioral health services. And this is sort of seen as low-hanging fruit in a lot of places, using telemedicine or funding a better pool of mental health providers and integrating that with primary health services. Yeah.
Sorry, what do you think the Congressional Budget Office estimates that this will be for next year?
God, that's such a good question. I'm so glad you asked that. Wow. I don't know if everyone caught it. So what Sarisha was asking, I think, was what does the nonpartisan Congressional Budget Office estimate the ACA will do to the deficit? And this is going to be multiple choice. Increase it significantly, increase it slightly, no net impact, decrease it, or can't say. I came up with those choices fast. You guys appreciate that. So what do you think? Increase it significantly? Increase it slightly? No net impact? All right. Decrease it? Can't say. All right. Nice spread there. Well, until about 2 months ago, the correct answer to this question would have been decrease it, according to the projections. But I learned just recently that there was sort of an obscure footnote buried in a report from April from the Congressional Budget Office that said, right now, this has become so complex, there are so many moving parts, so many delays in implementation of certain features that they can't actually estimate a net fiscal impact over time of the entire law. Now, they can estimate the net impact of the coverage provisions, the expanded coverage under the Affordable Care Act, which is what we're going to talk about next. But I think it's interesting because there are a lot of misconceptions, obviously, about the ACA ballooning the federal deficit, and there's very little ammunition, I think, for that argument right now. But again, there's healthy debate over where this is going. All right, Chad, remember, who, in addition to being an illustrious beer entrepreneur, got his insurance previously in the individual market. So he, under the ACA, becomes one of 24 million people expected to enter this revamped individual insurance market, or what we call the healthcare exchange or the healthcare marketplaces. He's required to purchase a plan, but the options are now more affordable and more reliable for him. Every plan in these exchanges is required to cover a package of 10 essential health benefits. Of course, it's always debatable what is essential, but these are things like inpatient care, outpatient care, lab services, so forth. And with the help of a subsidy from the federal government, he's able to get a plan that costs him $106 a month, which is the median post-subsidies price of plans in Washington state. He gets preventive care without paying out of pocket at all. And his two employees, these youthful fellows, 22 and 24, jump on their parents' plan because effective very soon after the ACA became law, anyone up through age 26 could hop on their parents' plan for insurance coverage. Very, very nurturing environment here. So how did Chad even hear about this? Chad, he's in the microbrewery. He's not wandering around every day trying to, scout out the best, most competitive insurance option. So he was hit with a barrage of advertisements in Washington state in this past year, trying to plant subtle messages that he shouldn't leave everything to chance. He's a fan of indie rock, and he happened to come across Death Cab for Cutie on a bus tour promoting the enrollment in the Affordable Care Act. And so all this led him to the Washington State Health Plan Finder, which is the web portal for enrolling in private insurance plans and Medicaid now in Washington State. And he was able to shop around there. It's kind of an Expedia, Orbitz-like experience, compare prices of plans with some transparency. And he felt like an empowered consumer doing this. Now, as you know, not every state has their own healthcare exchange website. And this is a snapshot of where we are right now. You can see the dark blue states, 16 of them, plus D.C., have or had their state-based websites set up and their state-based exchanges, but still a majority of states are relying on the federal marketplace, known as healthcare.gov. And even some of the states who attempted and invested a lot in trying to set up a state-based exchange, like our neighbor to the south, Oregon, struggled with that. This is healthcare.gov, and this may have slipped under the radar, but back in the fall, this site was having significant IT issues. But the hope is that it, functions similarly to the Washington Health Plan Finder. And I think this is kind of, if you're going to take away maybe one thing, I hope you take away 30 or 40, but if you take away one thing from this talk, this is maybe one of the key things here. So this shows trends in enrollment through the exchanges, through the first enrollment period, which started back in October of 2013 and wrapped up sort of with a fuzzy termination date in April of 2014. The dark line there represents overall enrollment, including both the federal and state-based marketplaces. The red line is the federal exchange, and the green line is the sum of the state exchanges. And does anyone know what happened right around here that bent the curve? The website started working, exactly. And you can see the surge in the red curve. And then this sort of inflection point here is what you generally expect to see because people, like most of us, procrastinate and sign up at the last minute. And so there was this surge in March, and the overall enrollment figures ended up beating even sort of the rosiest expectations that were put out there. So I feel like this question should be asked in every grand rounds. But one question that comes up is, are there enough guys like this out there? And for those who don't know, this is my colleague, Chief Resident Dr. Albie Ackel, who's looking both very young and very invincible, I think. And so, you've heard a lot of discussion about, are there enough young, healthy people, young invincibles enrolling in these plans? And the sort of target figure that was bandied about was 40%. We need 40% of the people enrolled to be in the 18 to 34 demographic. And this is simply because that would be the proportion of the demographic who would be, the proportion of the eligible market for the exchanges who would be in that demographic. And we ended up overall coming in substantially lower than this at 28%. there's a range of opinion on this. There's probably a range of opinion in the room. But the most trustworthy health economics resources I've found suggest that, yes, with fewer, younger, healthier people in the exchanges, you're going to see some increase in prices in coming years. The insurers are going to raise prices a little, but not to an escalating or destabilizing rate, maybe a couple % increase in premiums passed along to consumers. Time will tell. Big picture, there are generally more insurance companies and more health plans getting into these exchanges for next year's enrollment period, which, if anything, should be a marker of competition and hopefully more manageable prices. How do the prices actually compare? Well, it's very difficult to compare the prices of private insurance plans under the ACA in the exchanges and plans before the Affordable Care Act. It's an apples and oranges thing, and that's for 3 reasons, basically. One, all the plans in the ACA exchanges have to cover that package of 10 essential benefits. They're generally more robust plans, whereas a lot of the plans pre-ACA were kind of skimpy, bare bones. A lot of people would argue they're not true health insurance, kind of catastrophic coverage only. 2, the sticker price of a lot of plans before the ACA was not representative of the actual final price, because someone would come along shopping, they'd see a sticker price, $80 a month, that sounds great, then they get risk stratified, and because of their COPD and their CAD and diabetes and a host of other issues, it ends up costing them several $100s a month. And then third, the other reason it's different is we now have a lot of tax credits that lower the prices for individuals in the exchanges. The RAND Corporation, which is generally a nonpartisan think tank that tries to look at issues like this, compared the cost of premiums in the exchanges in this past year to premiums in the same markets before. And overall, there's high variability between different markets, different states, but prices were generally stable. And in the federal exchange so far, about 87% of people receive some degree of subsidy. And just as a reminder on this, subsidies are essentially tax credits that are available to anyone who makes from 138% of the federal poverty line, which is about $15,500 a year, up to 400% of the federal poverty line, which is about $46,000 a year. And it's a sliding scale, and about 87% of people fall into that range. So the average post-subsidy monthly premium in the exchange, in the federal exchange, was $82 a month, which kind of hit the target of this, comparable to a cell phone plan range that some people, certainly the Obama administration, were hoping for. Okay, then we have Michelle. So Michelle, who had been uninsured previously, her world is essentially turned right side up by the changes in the ACA. So she now, if she's living in the right place, can access Medicaid up to 138% of the federal poverty line, and she becomes one of 13 million new Medicaid enrollees. The federal government picks up most of the tab of that expansion. The states pick up a small percentage of it. And she gets preventive health and wellness exams that may be covered, depending on her state and region, at no out-of-pocket cost to her. And perhaps she has a greater choice of physicians. And the law does some things to try to expand the pool of Medicaid providers. As many of us know, Medicaid generally does not pay such competitive rates. For last year and this year, the Affordable Care Act does increase Medicaid reimbursement for primary care services to be on par with Medicare reimbursement rates. It's an ongoing debate now whether that's going to continue beyond 2014, but the hope is to grow that workforce. And it's impressive what happened right here in the UW system in this past year around the mobilization for enrollment in all of these plans. So the UW established this HICS-ME task force, which is Health Insurance Exchange Medicaid Expansion Task Force, to basically mobilize in a really proactive way around enrollment. They trained and certified 93 in-person assisters who you may have seen around, especially at Harborview, strategically located with computers, also here at the U, enrolling people in Medicaid or in the health insurance exchange products, or pointing them to the website. There's a phone hotline established, and patients were supported in their enrollment via the website, which in Washington State, it had a few non-trivial hiccups, but it generally worked pretty well out of the gates. And these are the results, the best data I can find so far on Washington State enrollment. So between Medicaid and the insurance exchange products, Washington's enrolled almost 1 million people, and 15% are in these qualified health plans, which is code for a private insurance product in the exchange. And then you have a smattering of other people enrolled in Medicaid. And you notice that 42% are people who were already enrolled in Medicaid, but a majority are people who were not insured through Medicaid previously. And so the Office of the Insurance Commissioner estimates that total in the last 5.5 months, there's been probably a decline of 370,000 in the number of uninsured in Washington State, and this is off a baseline of 1 million, which is a pretty dramatic shift in a relatively short period of time, I think. So, as many of you know, the story is not played out the same way in every state, and I feel like I could have pulled this off awkwardfamilyphotos.com or something. It's like, Clarence Thomas doesn't look too pleased about this, and I don't know if Mark Tonelli's here, but it looks like Ruth Bader Ginsburg's kind of listing the port. So, any case, the Supreme Court weighed in on the constitutionality of the Affordable Care Act, and they weighed in on two things. One was this requirement to buy insurance, the so-called mandate constitutional. They said yes. Two, could the federal government mandate a Medicaid expansion across the country? And they said no, that's coercive. And so this is the upshot of that, where you have 21 states, actually 24 states, who are not moving forward with Medicaid expansion at this point. And this is a real challenge because it leads to this coverage gap. You know, in theory, the ACA was supposed to provide this kind of nice umbrella for folks who were either incomeless or up to 400% of the federal poverty line. But what's happened in states that are not expanding Medicaid is that there's this pool of people who are too wealthy for Medicaid and too poor to qualify for subsidies on the private insurance exchanges. And this is mainly because the average eligibility cutoff for Medicaid in these states is 46% of the federal poverty line. So these people represent probably 5, 6, 7 million people who are not able to get insurance in those states. This has all sorts of ramifications for hospitals, too. I'll come back to that in just a couple minutes. This is survey data from Gallup. This is the polling tracking the percentage uninsured over the last few years. And, you know, this is correlation. We can't definitively say that this is causally connected, but it is a pretty striking association that, you know, in late 2013, the national uninsurance rate was 18%, and it's dropped down relatively precipitously to 13.4% as of the end of March. So I have a physics question for everyone here. This is a three-legged stool, which you see associated with the ACA from time to time. And what happens when you kick one of the legs out of a three-legged stool? Yeah, disaster, right? Falls over. So the ACA insurance markets are often represented as a three-legged stool, right? There's guaranteed issue, which is insurance speak for insurance plans must issue coverage to people. There's the mandate, which means individuals have to buy coverage or pay a tax penalty. And then affordable care. And the logic here is that everyone likes the rule that insurance plans should have to issue insurance to everyone regardless of pre-existing conditions. But if you're going to compel them to do that, then you have to require people to buy insurance, because otherwise healthy people will opt out of the market, the pool of insured will get sicker and more expensive, premiums will rise, and we enter what folks like to call the death spiral. And that doesn't sound good. So if you're going to require people, though, to buy insurance, you have to make the insurance affordable. And that's where the subsidies come in. That's where the Medicaid expansion comes in to make the care affordable. So,
Yo, Jake.
Yeah.
By how much will the ACA reduce the uninsured population?
Man, you guys are right on point today. That's so sharp, Mike. So by how much will the ACA reduce it? Well, I would maybe reframe it this way. By 2024, the ACA is expected to reduce the number of uninsured people in the United States from 57 million, which would have been projected without the ACA, to what range? And there are different estimates. Economic forecasting, demographic forecasting is always variable, but 32 to 37 million, 26 to 31 million, 16 to 22 million, or 5 to 11 million. A, B, C, D. Optimistic, yes. So in fact, it's B. This is the estimate at this point. And generally, these are folks who fall into one of a few categories. People who are in states that are not expanding Medicaid, therefore can't get it. People who are too poor to qualify, too poor to afford insurance, essentially, so they're exempted from the mandate because of hardship. People who just don't want insurance and will go ahead and pay the penalty, and then undocumented immigrants who are not covered in any way by the Affordable Care Act. So finally, in the closing couple minutes here, what might this mean for you as a provider, patient, and citizen? And I'm just going to offer a few brief thoughts here. I mean, this could be an entire 900-hour discussion. So as a provider, what might all this mean for us, big picture? Well, there are various cross-cutting financial trends, and I think it really depends on what type of provider you are, meaning structurally your role, not your personality so much, and where you practice. So, for instance, in states that are expanding Medicaid, like our state, safety net hospitals like Harborview have actually seen revenues exceed forecasts because of the revenue from the Medicaid expansion and the dramatic decrease in uncompensated care. It's a boon to those institutions. States that are not expanding Medicaid, safety net hospitals and such places, they're getting squeezed because their disproportionate share payments, which are the extra payments to safety net hospitals, are declining and they're not getting additional revenue from Medicaid. One example. I think generally for providers, primary care folks in rural areas are likely to see some increase in their reimbursement through provisions in Medicare that increase reimbursement for primary care services, and as I mentioned, Medicaid, at least for this year and next year, increasing reimbursements to primary care services. On the flip side, specialists and folks in higher resource locations may see decreases because the reimbursements from a lot of the new exchange plans may be a little lower. In order to keep the price of those plans lower, you have to control costs somewhere. It's an open discussion, remains to be seen. I think something that we're seeing a lot of already here is the rollout of these accountable care organization initiatives, medical homes, and sort of fits and starts efforts to transform the delivery system. Some of this would be happening without the Affordable Care Act. But a lot of it is influenced by the ACA because the Center for Innovation and the Center for Medicare and Medicaid Services generally pump a lot of resources into demonstrating ACO projects and sort of bundled payment projects. And so all of this is kind of grassroots taking hold. I think providers, physicians in particular, are always curious about this. The ACA has only a very modest initiative that addresses medical malpractice. $50 million in the law are set aside to pilot different programs to look at ways of improving our broken and extremely costly malpractice system. But I think generally what we're looking at is lots of little innovations that may converge in some ways, but persistence of complexity and a lot of fragmentation. So hospital systems are growing, buying practices. We may see more integration along those lines, but I still kind of think there's a good chance we'll be, asking medical students to obtain faxed medical records from other institutions 5, 10, 15 years from now. As a patient, what might all this mean? So I think it certainly makes it easier to understand and obtain insurance, although not for everyone. But I think it's important to remember that health insurance does not equal health insurance access. And the ACA does a reasonably effective job of expanding insurance coverage, which means the demand for healthcare services, and particularly primary care services, are going to increase. What's it going to do to increase the supply to meet that increased demand and make sure there's true access? It does a lot of things, a lot of little things, and some big things along that front. It increases funding for the National Health Service Corps. It increases primary care residency spots. It sets up initiatives to train more providers in community health settings, such as teaching health centers. I don't know if Dr. Freddie Chen is here, but he's been spearheading that effort with funding under the ACA. Even if you improve access, you still have not necessarily achieved health. And we've seen various studies in the past few years that look at the impact of health insurance and health access improvements in places like Oregon and Massachusetts, and have variably demonstrated, improvements in financial security and some improvements around the edge in health, which was seen in Oregon, or in Massachusetts, actually a reduction in all-cause mortality that could potentially be attributed to the Massachusetts healthcare reform, which is very similar to the ACA. But at the same time, there's a premium on continuing to innovate on quality and cost control as we do all this. So there's promise of change in the delivery system and better coordination of care for patients so that the whole care team of providers, physicians, nurses, medical assistants, pharmacists, are all involved in a more integrated way in the patient's experience. And then finally, as a citizen, what can we expect? And I think as citizens, in some ways, our principal role in this is as funders, as taxpayers. And so I kind of come back to the name here, the Patient Protection and Affordable Care Act. What are we really talking about when we talk about affordability? And I think there are kind of three dimensions to affordability that affect all of us as citizens. First, affordable insurance for the healthcare consumer, and that's what we've talked about a bunch today. And I think the ACA certainly makes a lot of headway on this front to make insurance more affordable. The budget implications of the law, which are kind of too complicated even for the Congressional Budget Office to project at this point, but will certainly affect the bottom line and our pocketbooks as taxpayers. And then sort of the holy grail is figuring out how do we bend the cost curve long term. And the ACA sets out through the Innovation Center and through a host of other initiatives to find ways of identifying things that work with the hope of replicating and scaling. But it doesn't jump in and wholesale change the way we pay for healthcare at the macro scale. So I think we can see, increased stability in insurance and access, but still a lot of flux. I mean, kind of a period of semi-controlled turbulence for the foreseeable future. Which brings us back to the fox and the hedgehog here. And so Archilochus described these two characters in kind of a dichotomous way. The fox, as we know, is clever, comes up with many different approaches to a problem, very creative. The hedgehog, and hedgehogs, we don't see a lot of them around here, but they're little spiny, furry creatures like porcupines, and they can do one big thing, which is if there's danger, then they hunker down and they put their spines out. So, I was kind of thinking about the Affordable Care Act. Is it a fox or a hedgehog? And I think after everything we've discussed, clearly as a matter of structure, it's very much a fox. It's a series of complex and intricate initiatives and rules that in some attempt to tackle this system's problem effectively. But I would argue that there is the spine of a hedgehog in the Affordable Care Act in that the law knows that if you want to fix or change anything in the healthcare system, you have to touch everything in the healthcare system. And it doesn't do this in a dramatic hedgehogian fashion, by doing something like, say, lowering the Medicare eligibility age to 0. That would be more of a traditional hedgehog approach. But it does touch virtually every element of the healthcare system in some way. And I think we don't even know how that's going to play out yet in the coming years and decades. So, in conclusion, our healthcare system was and potentially is, for many of us, in a state of crisis. The ACA, I think, is public policy. It's complex. It's more evolutionary than revolutionary overall. And it seeks to transform our system through these measures here. And as a philosophy of health system reform, I think it's rooted in pragmatism, what is politically possible. But there is this decisive shift in changing everything in the system in some way, making it more affordable, sustainable, and high quality. So with that, I'd like to thank all these folks who were instrumental in making this happen. I could not have done any of this without you. And particularly Chris Vanderwalker, who was my first mentor in this project. And then the program, Ken and Kelly and the office staff who have been great support. Dr. Bremner for giving a lowly VA chief resident the opportunity to give a grand rounds. My friends and colleagues over at the VA. And then finally, my conciliary, my parents, and my wife Annika, who's here today, who have been my closest mentors and advisors as I tried to understand all this stuff. And thanks to all of you.
Award presentation here near the end. I think we probably have time for one question.
Yeah.
What's the history behind the development of this act and the geniuses that constructed it?
A nice short answer to that one. So I guess I'd hit on a few things here. The Affordable Care Act brings together several different ideas that developed in health policy throughout the 80s and 90s and the first decade of the 21st century. The insurance market reforms, and particularly the idea of setting up a market where insurers had to offer insurance and individuals were mandated to buy insurance. As some of you know, that idea came out of the Heritage Foundation, which is not generally regarded as a sort of left-leaning think tank. And in the 90s, this idea was proposed as a way of providing universal coverage on the basis of personal responsibility, that we all end up consuming health care at some point, and so we all have responsibility to pay into the system. So that concept is kind of rooted in that. The public insurance expansions, I think, evolved as ways of bridging gaps in terms of people who would not be able to afford insurance in the exchanges in any way. And then there's a constellation of other features, and there were a lot of health economists and policy folks involved in trying to package those together in some coherent way.